be. I'll now turn the webinar over to Heather.
Thanks, Wendy. Good morning, everyone. Today, I'm going to be presenting to you Somebody's Watching You. What are your PDPM, PEPR, and facility risk areas? Our main objective today will be, we're going to go through the various auditors that are out there looking at your data. We'll talk about what their intent is and what the steps and systems you need to have in place to mitigate your risk areas. We will take a hard look at medical necessity, function, which is essentially section GG, length of stay, and discharge planning, because these are the areas that we are at most risk for if we are considered an outlier. Hopefully by the end, you'll be able to describe data analysis and ways to decrease your risks of being an outlier. Okay, to get us started, who's watching us? It seems like everybody, right? We know the granddaddy of them all is CMS. We also have the OIG. The OIG heads up our fraud and abuse task force. We have the MACs and the RACs, and we have the UPICs. All of these folks have one main purpose. It's to monitor, identify, educate in order to reduce Medicare fraud and waste. The next slide, actually the next few slides, we'll go over just a series of articles that have come out within the last year and a half. These articles really speak to what's going on with PDPM and the trends that they're seeing. We'll talk quickly about these, about the pandemic and how that's functioning when it comes to audits. And lastly, we'll talk about the uptick we're starting to see back in audits now that our moratorium's over. This first article comes to us from McKnight. You can read it on your own. Basically, it highlights how well we did with PDPM in the first quarter. As you recall from the initial PDPM training that we all went through, PDPM was considered a, air quote, budget neutral program that they were putting in place, or payment system in place. However, this article outlines that the overall findings is that most of us did much better than they expected. In fact, a little over 91% of us were considered winners, or that we did better, meaning we enjoyed positive PDPM impact, while only 8.5% saw a reduction in their rate payment. The article goes on to say that their federal regulators were expected to go on to recalibrate rates in those areas that we did so well in. Nothing surprising there, right? If we do really well, they're going to take a look and probably make some adjustments to get it back to budget neutral. And they do warn us in this article to expect tougher audits. So the next slide talks about some trends and outliers with PDPM. Our average daily rate in Q3 of 2019 was about $566 and change. Then well into Q3 of 2020, we were at an average of almost $594. And this was during the COVID outbreak. So that's a difference of $27 a day. If you annualize it and you look at that reimbursement, it's almost $100,000 annualized in increased reimbursement potential with PDPM. I think we're all shocked to hear that and see that, because we did expect, and I think most of us in this field worried that we would not be what they consider winners in PDPM payment system. The next slide just gives you a nice bar graph to show you the uptrend. The next article I'm going to talk to you about is the rise of data and how it can be used against us, okay? We've been dealing with data crunchers and collectors for a while with our value-based payment system. We are very accustomed to data analysis that the partnerships with the Medicare Advantage plans have taught us, right? The ACOs have taught us to be better documenters, better communicators, and in turn, better providers. So we're very accustomed to collecting data with regard to hospital readmissions, lengths of stay, episodic cost. We know that that has to show that it's low, and all while our quality measures are high. So this data collecting and analyzing has now become a stronger focus with the federal government, as well as the independent auditors. So your potential risk of False Claims Act cases is based upon the people crunching the data. So this article goes on to talk to us about how the claims data and similar information become increasingly available to the companies that are looking for fraud and abuse, and how they're starting to data crunch and data analyze the way our ACOs have done this in the past. The next article goes on to talk about COVID money. We all know there was extra money that was handed out to deal with the epidemic. We also know we had a few waivers added during this time frame. This article cautions you on the appropriate use of that money in the waiver programs. And basically, just overall, it's telling you, make sure if you used any of those funds or waivers, be prepared to prove that you followed the guidelines. Make sure your documentation is in line. Nothing new there. The next article just talks about, well, first of all, let me say, wasn't it wonderful to have a break? Next slide, Scott. Go back, Scott. The next article, this article talks about the break we had with audits. All good things must come to an end, and we're all seeing it. The moratorium on the halt of audits has changed. We are back to getting audits. We are back to being in redetermination phases and working with the RACs and the MACs. So this article is just strongly reminding everybody that during the time that we were struggling with the epidemic, many of our employees took on different roles in the SNFs. Maybe that was because, you know, one of the RNACs, the social worker, the facility rehab director, the DON may have been exposed to COVID, out with COVID, quarantining for 14 days, sick with COVID, taking care of a sick loved one. So all of our jobs kind of got shifted around. All of us assumed different responsibilities and added responsibilities at some point during the pandemic. So what this article is cautioning you on is make sure that you're revisiting job duties and who's in charge of audits and due dates and collecting data and painting our picture and making sure we're following guidelines, because audits are back. The next is just a screenshot straight from the CMS website. If you haven't spent any time on CMS's website, just Google their fee-for-service compliance program, and this will pop up. It will actually take you through each of these categories. I'm mostly going to concentrate on the Medicare review and education and the recovery audit portions, but it really goes through and explains and highlights what each of these programs do. So if you haven't spent much time, it's a great resource. Okay, the first thing we have to do with any compliance program is ask ourselves, honestly, is it effective? Next slide goes over CMS, what CMS actually does through its compliance program. CMS implemented a comprehensive error rate testing. We all know that as CERT, the CERT program. What it's used for is to measure the rate of improper payments for the Medicare program and the Medicaid. So what it's looking to do is say, okay, how effective are we on making sure that we're not dishing out improper payments? CMS and its contractors use an error rate, an error data collection. So they have rules and regulations for it. The next slide talks more about the CERT program specifically. It looks at everything using any public money for CMS, Medicare, and CAID. So some people listening will say, well, I don't know that this applies to me. If you're using any funds from Medicare or Medicaid, this applies to you. So it's a bit complicated, but the error rate for 2020 was 6.27 of improper payment rate for a total of. So they're saying they had a little over 6% in improper payment rate, and it came down to almost over $25 billion in improper payments. So you can understand at that level why there is a focus on audits, compliance, making sure we're doing and following the guidelines. You may be included in a CERT audit. If you are, they'll reach out and request information. You can appeal the CERT findings. You'll see that, like I said, 75% of SNF improper payment errors were because of insufficient documentation. I mean, doesn't it seem like every time we talk about audits, it comes down to what? Documentation. Most of this 75% of documentation insufficiency comes from missing certifications and recertifications. Now, I don't want you to confuse that with therapy certs and recerts. These are actually Part A physician certifications. So all in all, what we really need to focus on is making sure that in our triple check systems in the facilities, our beginning, mid, and end of month checks and compliance, that we're looking to make sure that we have this certification in place. Because if we do, that's 75% of the improper payments. They're tagging that 75% of why there's improper payments stems down to the certification and recertification. So we definitely want to make sure that we're taking a look at that. All right, let's start with the first group, the MACs. Who are the MACs? They're the Medicare Administrative Contractor. They're a private healthcare insurer awarded to a specific jurisdiction to process Medicare Part A and Part B claims, DME, and FFS beneficiaries for our beneficiaries. They used to be known as the FIs, or the fiscal intermediaries. CMS relies on the network of the MACs to serve as the primary contact between people in the program and the enrolled healthcare providers. Okay, some of the other things they do besides processing claims is enrolling providers, handling provider reimbursement services, and that process, which is called the determination phase or redetermination phase. The RACs handle the original denial. The MACs handle the redetermination request. They also handle the LCD, or the local coverage determinations. This is well worth your time to invest in looking at the LCD. As a therapy provider, we train all of our facility rehab directors to use the LCD as a main source or a main guide to include in their audits. The LCD specifically spells out each CPT code and the guidelines for its use, and more importantly, what will get paid and what won't get paid. It's a cheat sheet. It's a wonderful cheat sheet to add to your compliance program, your therapy audits. Use it as a cheat sheet to see what's paid and, more importantly, what's not going to be paid. One example I do like to share with you is therapeutic exercise. It's 97110. In the LCD, it defines exactly what you need to use this, what gets paid. It tells you what's considered overuse of it, because it's the most overused, underskilled CPT code is therapeutic exercise. So as part of our compliance and audit, we make sure that we're looking at that code for each episode of care that it's used for. You know, the LCD tells us you can only use that 10 to 12 times. So it's a great data point to go in, just quick up, go in, take a look and say, okay, here's this episode of care for Mrs. Smith. How many times did we bill for 97110? We know that if it's over 12, that we better have documentation in place. For one, we shouldn't be using it more than that, but we're going to want to make sure our documentation is in place because they've already told us it's the most overused and underskilled code. So we train our therapists to make sure they're looking at the LCD and using it. I spend a little more time talking about this because I think if you go back to your facilities, you want to go back and say, are we using the resources that we have to keep us from being red flagged and becoming outliers, which sets us up for more audits, which we all do not want. Okay, the next slide is a nice picture of the MAC jurisdictions. I just put this in here because I want you to know that in PA, it's Novitas. So if you see anything from Novitas, you know that that's a MAC recovery, it's a MAC audit, and you're going to want to address it because there's obviously time frames that we have to get that data to them. Okay, CMS has compliance programs. One of their compliance programs is a target probe education, the TPE. It's run through the MACs. Most providers will never need TPE. It's intended to increase accuracy in very specific areas. So if you're drawn into a TPE, it's because your data has indicated you as an outlier. It could be, like I just talked about, it could be the overuse of 97110. What that would say is, hey, this facility is using this code more than their peers. Or 1/4 of, they've had significant more use in 1/4 than a previous quarter. So it's a high data analysis looking for unusual billing practices. You know, one thing I want to add here is they can be looking at your PDPM claims as well. So if you have some higher case mix groups running in your facilities compared to the national average, it could flag you for an audit. The next slide is a TPE fact sheet. And basically what this does is it just goes over how this all works. It's a nice resource for you to pull out, and it talks about the cycle of the ADRs and the process of the processing of the ADRs, and hopefully not the recoupment of any of the monies. Hopefully we get to keep that. If you take a look at the bottom right-hand corner, they go over some of the common claim errors, and no shock here, missed signatures on encounter notes. Missed signatures, encounter notes not meeting medical necessity. It constantly goes back to not meeting medical necessity. Basic documentation not meeting medical necessity. Missing or incomplete certifications and recertifications. So it's super important to have a system and a backup plan in place. You know, these are the things they're promising they're looking at. So make sure that your compliance and audit programs are incorporating this. Okay, the next group we're going to talk about are the RACs. The RACs are our recovery audit contractors. Okay, so what's their goal? Their goal is to identify and correct Medicare and Medicaid improper payments. They want to identify underpayments to providers and to provide information that allows CMS to implement actions that will prevent further improper payments or future improper payments. Pretty simple. CMS oversees the RACs, and they oversee their own Medicare recovery audit programs in accordance with the federal guidelines set up by CMS. Okay, let's take a look at some of the changes to the RACs. There were numerous complaints. Anybody that's been part of RAC audits have had these complaints. You know, we could get inundated with tons and tons of requests for more information and RAC audits. It costs the facility tons of money and administrative expenses just to gather the data, build the case, and send it back. I mean, we could see some facilities get 30, 40 at a time. And it was just completely unrealistic that you could spend that amount of time preparing that data all on the same dates. So recently, CMS put efforts in place to let us know they hear us. So now the RACs are accountable themselves for performance, okay? So now they're being judged. They have to maintain 95% accuracy scores. In a nutshell, the RACs have to maintain an overturn rate of less than 10%, okay? They can't take the money back from a claim that they're auditing or requesting until the second level of appeals. Before, they could take back the money immediately. And then we had to prove that we could get the money back from them again when we proved that we had the documentation to support. So obviously these were welcome changes. In the past, the RACs could select certain types of claims to audit. Now they must audit proportionately to the types of claims a provider submits, okay? They've also added more time for us to submit additional documentation, which is very helpful because it takes a lot of time to get your nursing and therapy documentation in place and build your case, paint your picture. Next slide. Okay, there's a word that we don't like to hear. It's called extrapolation. In the past, we know the RACs love to use extrapolation when they audit it. Well, now CMS said, hey, listen, you can't use extrapolation unless your facility has a high denial rate for an extended period of time, or you have excessively high dollar amounts due at a moderate denial rate. So you have to show, they have to prove that extrapolation is something that is, how do I say it? They have to prove that they're using extrapolation for a just cause. So in other words, they can't take 3 claims, say, well, you did X, Y, and Z in these 3 claims, so we're going to deny the next 50 you send in with these similar types of coding and such. They have to prove it more with a focused audit. Which brings me to the next slide. There are 2 types of audits. There are automated reviews and complex reviews from the RAC. An automated review is an improper payment, and it's obvious. It's a technical coding issue. Perhaps somebody billed for a timed code, maybe the untimed codes, speech pathology codes, a lot of them are untimed. And maybe they see that you billed two of these speech codes in one day. Well, you can't do that because no matter if you spend 15 minutes or 60 minutes on an untimed code, you only bill one CPT code of that. So anything in an automated review like that, they can just deny one of those codes because you're not allowed to do that. It's more technical. And in an automated review, the claim determination is made immediately. Now, a complex review, and that's really what we're used to, the claim is likely to contain errors. The RAC requests medical records from the provider to further review the claims. The claim determination is not made immediately, but after further review. Okay, this is what we're used to. We're used to pulling the nursing documentation, therapy documentation, then sitting down as a team and saying, okay, what did we do here? What supports this? Going back through, it takes time. We're going back through nursing notes, physician notes, and we're saying, hey, this is why we treated this patient. This supports and justifies medical necessity. The RAC has an approved issues list, okay? They can only audit based on an approved list. So what I did is I went through and I was able to sort by provider type, and I pulled out a few examples of RAC approved audits, okay, or issues that may go to an audit. The first one I'll talk to you about is the SNF medical necessity and documentation requirements. The stay must meet coverage criteria. That's what I just explained to you as a complex review. They can't deny the claim just based on reviewing our billing. They have to give us a chance to pull it together and paint the picture. An untimed therapy excessive unit or a SNF facility consolidated billing, those are both examples of automated reviews, and they can deny those just based on the billing. Okay, this next slide, we're going to take a break from talking about the audits and focus a little bit more on clinicals. I've mentioned medical necessity several times. So outside of technical reasons for denials, the next most frequent reason for a denial is what? We say it constantly, medical necessity. So if you look up medical necessity under CMS's definition, you'll see that our services must be safe and effective. They have to have a duration and frequency that is appropriate based on the diagnosis and the treatment. So there's set rules. It's just not willy-nilly. They must meet the medical needs of the patient. And how do we know that? Because we do evaluations. We set up evaluations. We look at the diagnosis. And these require the skills of a therapist. This is something that only a skilled therapist can provide. And sometimes I have to say, when we're reading and auditing documentation, the notes from therapists do not support that it took a skilled therapist's knowledge base to provide the skill. I won't spend a ton of time, but simply ambulating a patient, if your notes look like you're just feeding a patient, we have to make sure our therapists understand and are trained to document the skilled services that they provide. Okay, with all that being said, we need to take a look at diagnoses. When they crunch the data, they're looking at the data and we're being compared to our peers. So that's typically how you get flagged for audit. You may have an excessive long length of stay, or your PDPM might have high case mix. I've said that before. And they might be exceeding your peers. You may have exceeded KX modifiers for Part B services. There's lots of reasons that can put you as an outlier. I'm an educator for our company, among other things. So when I'm educating our facilities and our facility staff and nursing and our therapists, we're always talking about that setting the stage for success with our claims. Well, where does that start? It starts at ICD-10 coding, right? This slide is just a quick snapshot of our fast track form and a crosswalk form that we created for Section K. Let's talk about PDPM and how this goes with it. We know that the role of the I-20B within PDPM, because it's been hammered in our heads from the beginning of PDPM education, the I-20B sets the stage for the skilled stay, correct? It's not the reason they went out to the hospital. It is why if therapy is the skilling factor, this is the reason why the stay is skilled, okay? The main reason we need to be setting the I-20B as a team is based on the medical record. So we have to hope that we have the hospital records and we sit down as a full IDT team and we're saying, okay, what is the main reason their stay back with us at the SNF is skilled? Because that skilled stay, that I-20B is going to set the stage for the length of stay. And then that's going to determine the case mix group they fall in. If I were an auditor and I saw you had a long length of stay, I'd look at your I-20B. I would compare your length of stay versus the diagnoses indicated in the I-20B. We're constantly educating our teams and saying, hey, no, you can't use UTI. Some forms of pneumonia aren't good to use. Dehydration to support your skilled stay in the SNF. Because, really, let's face it, resolves itself usually in the hospital, right? So we must choose the diagnoses as a team and discuss why it's skilled. The second screenshot on this slide is our crosswalk, MDS the speech. Okay, I included that in this education because, you know, they didn't expect, in PDPM, they didn't expect us to do as well as we are all doing in Section K. We know that Section K is an area of focus, so we developed a tool. We worried about doing well in Section K before PDPM even started. You know, how are we going to make sure that that's done collaboratively? How are we going to get dietary, nursing, MDS, and speech all on the same page with Section K? So this tool here basically guides the speech and MDS team to, it kind of pairs our language with what they understand and vice versa. And it's really, this tool is really just used as a lead into discussion to make sure we're collaborating on that score. Okay, the next slide just goes back to the racks, and I include this, and it's quite confusing, but I'm going to try to break it down. And just bear with me because there's a reason I want you to understand this. Okay, so initially we talked about the racks and how we could get inundated with audits. And I can't tell you how many times we've been in a building consulting with somebody and they say, we just need to get out of these audits. There's too many. We had 18, now we have 36. I can't keep up. I just want out of this. And, you know, we try to guide and say, okay, so we need to be looking at the trends and seeing what we're not doing right, what we continue getting flagged for, and start to address that on the floor. But we don't have time to address that on the floor because we're too busy putting these together. So it's a constant chasing your tail. So the racks have limitations. That's the good news. There is an equation that you see on this, and I'm going to break it down for you. And it allows them to calculate error rates. Error rates determine how many audits they're allowed to request from us in any 3 45-day cycles. Let me tell you that your error rate is calculated after 3 45-day cycles, and it readjusts your ADR limit for the next 3 45-day cycles. I'm going to break it down a little further. If you're a provider and you bill, say, 22,000 claims in 12 months, the baseline ADR limit would be that number of claims, 22.5, times 1/2 of 1%. That equals 112 claims, right? The limit is 112. Now the ADR cycles, there's 8 ADR cycles in the year. So you take that number and divide it by 8, and there's 14. The RAC can only request 14 ADRs per 45-day cycle. Next slide. Take a look at this chart, okay? I went through that equation with you for a reason. Say you are at the 10 to 20%, okay? So that's 14 ADRs we figured out. They're allowed to request 14 ADRs. Say you don't take the time and track and trend and go out on the floor and address issues that you're finding in these ADRs. Well, in 3 45-day cycles, your error rate's gonna readjust. Say you did worse and now you are at 25%. So that steps up in your denial rate, okay? Now they're allowed to do baseline times 2. So those 14 audits became 28 audits. Do you see my point when I say we cannot not have time to track trend? And as a team, therapy, nursing, everyone get out on the floor and fix what we're finding that's flagging us. We don't have time to not do that. Okay, the next few slides talk about the OIG, the Office of Inspector General. The mission of the OIG is they're mandated to protect the integrity of the health and human services programs, right? They hold accountable those who bill under the health and human services programs. They identify opportunities to improve the economy, efficiency, and effectiveness. It boils down to, are we using the monies effectively and efficiently and appropriately under the guidelines? The main objective of the OIG is to find Medicare and Medicaid fraud. Plain and simple. You can take a look through the next slides. You can take a look at an OIG work plan and what they're actually looking at. Advanced slides. We have several slides that talk about their focuses. It tells you what your audit risks are based on what their focuses are. The one thing with the OIG, they put it right out there. They tell you exactly what they're looking for. So they're looking at use in the reporting under the CARES Act Provider Relief Fund. And did you use that according to the requirements? They're looking more now because of COVID at the use of telehealth. We didn't use telehealth much, but during COVID, we were given waivers and some facilities used more telehealth. They're looking at infection control and complaints. Well, that's not surprising, right? They are looking at your infection control and emergency management plans, all due to COVID. They're looking at your upcoding by the Medicare Advantage organizations for higher reimbursement amounts. They're looking at the PBJ and quality of care. And they're really focusing on therapy. They're looking at the use of the KX modifier to make sure you're monitoring the use of KX. You know, in our facilities, we make sure that our therapists are doing a good job monitoring the use of KX. And some patients, because of need, will require care outside of the $3,000, right? But we work with the entire team, including the administrator. We're discussing that. Why? Why our documentation is there to support the need for 3 extra visits. They're looking at accuracy of Part B billing and payments. Okay, now we're going to go up to the UPICs. They are the ultimate data crunchers. Okay, what is a UPIC? Unified Program Integrity Contractors. They perform fraud, waste, and abuse detection. We want to keep them out of our facilities, right? None of us want a UPIC audit. They can use, and they do use, extrapolation. In Pennsylvania, our UPIC contractor is called Safeguard Services. So whoever's in charge of looking at emails, snail mail that comes in, anything that says Safeguard, you want to go back to your facility and remind them. Anything that says Safeguard requires our immediate attention. Next slide. The comparative billing reports. Okay, so comparative billing reports, or CBRs, and the program for evaluating payment pattern electronic reports. That's the PEPR report. Let me explain it. Every facility gets a PEPR report. Every facility does not get a CBR. As much as I wish everyone could get a CBR, they don't. You have to be considered an outlier to get the CBR report. It's not like PEPR. PEPR reports are loaded into your profile on the website once a year. You'll get notice if you're an outlier, and then you can check for your CBR. So what does the CBR report do? Well, it looks through your use of CPT codes, KX, and threshold against your peers. It has a ton of information. If you get a CBR report, this is when you need to fall back on those KX reports that you can run in your buildings and make sure you're not in that outlier status. The next slide just tells you the usefulness of the CBRs and why it's valuable to CMS and why it's valuable to you as a provider. It really gives you a tool to look at your patterns that are different than your peers. Okay, let's focus now on the Pepper report. It's available, like I said before, to all providers and also to auditors. Okay, it's almost like they're giving the auditors a roadmap to come in and deep dive, right? The Pepper is, again, a program for evaluating payment patterns electronic report. It always looks at statistics for the last 3 consecutive fiscal years. Okay. In April, we saw some changes with the RUG targets and focuses that will be phased out because now we're PDPM. But I have to caution you, until it completely falls off the 3 fiscal years, you will still be scrutinized for RUGs data. With PDPM, we are seeing new target areas. One of the target areas that we're seeing is the 3 to 5 day readmissions. Why do you think we're seeing that? Why would they add a target area of 3 to 5 day readmissions to the hospital? Well, in a nutshell, they were concerned that providers would readmit patients to the hospital because why? Because it requalified us for that lucrative 300% payment for days 1, 2, and 3 of any new stay. This slide, next slide, actually breaks down what the numerator and the denominator is and how they figure that out. If you're interested, you could certainly take a look at that. This here is just the next page is a screenshot of on the Pepper report what you might see if you're an outlier. Say you were an outlier in the 3 to 5 day readmissions. You see it's broken into target group, suggested interventions if you're at or above the 80th percentile, and then suggestions if you're below the 20th. So what they're basically saying is make sure your documentation is in place to support that hospital readmission. So this is what the Pepper report, this is just a snippet of what that Pepper report will actually give you. It really breaks down where you're putting yourself at risk. The next 2 slides are good examples to review at your leisure. They're really just how readmissions are identified, and it just really gives you a breakdown of a patient and the documentation and how they either could be a risk factor and identify trends. Okay, so now you've triggered as an outlier. What on the Pepper report? What do? Panic? No, you don't panic. There are several reasons why you could be an outlier, none of which it guarantees it's a compliance issue. You want to review the report and respond to issue. Your response to the issue should be part of your compliance plan. Okay, so you guys are getting this trend here. The Pepper report identifies where you have risk areas. You want to analyze it using your whole team, include therapy. Okay, guys, why are we here? Why are we triggering over the 80th percentile here? You want to look at what you can do. Okay, sometimes you're an outlier because you have a specialty program. What could trigger you with the specialty program? An Alzheimer's facility. You may be taking higher acuity patients. Okay, so that could automatically trigger you for as an outlier. And if that's true, you just want to make sure your documentation is in place so you're ready if you are flagged for audit. You also don't want to forget to look for errors. Sometimes you are pushed into an outlier category because maybe you made a mistake on MDS. Go back and deep dive those MDSs and say, okay, were they thorough? Were they correct? And if you find a mistake, you want to resolve it and get yourself, it could take you out of the outlier status. Okay, so the next slide that we're looking at is just the SNF pepper retrievals. I include this just as an eye opener. If you look at our state of PA, we are orange. That means only 20 to 39% of SNFs even access their pepper report. So at most, 39% of SNFs pull their pepper report, even pull it. That's too low. We're leaving huge amounts of data collection, information on the table. Pull your pepper report. If you don't know how, go to your therapy department. Ask them to help you interpret it. Okay, the next few slides outline the importance of accuracy on GG. I am not going to beat up GG. We have beat this. We have educated on GG. We all know it's important. We know the main thing is we have to be scoring GG in a collaboration. We know the OIG and the MACs have told us that this will be a focus area, so we shouldn't be surprised. We've noted an increase in the number of denials from Humana and Aetna already in my areas due to the lack of supporting information on the record for how section GG was coded. The next slides give you lots of pointers that you should include in your training and protocols for section GG. I'm not going to go over these one by one. I think as a team, you all can take a peek at these. They're self-explanatory. You want to go back the next 3 slides and take that back to your teams and say, okay, do we have a compliance program that encompasses these risk factors? One reminder I want to give you here is how to score GG and how they count for PDPM. So maybe you want to use something like this to, do a quick brush up and reminder to your staff. The next slide goes over our paper GG tracker. I include this because we believe it's extremely important to work as a team. We need to collect data on usual performance as a team. A lot of customers will say, why don't you have your interface button turned on? Because then the information from therapy magically slides in. Well, we don't do that for a reason. If therapy data for usual performance just slides in on the MDS, it shows that none of us did any sort of collaboration. It sets us up for failure, and we won't do that with our customers. This form here, the snippet that's very hard to see, it's just a general idea of what we do. It's our paper tracker. It encourages us to work as a team. It's a data collection form, but I do have to tell you that we have used this data collection form as a way to support, because it's signed and dated, and if it's during within the GG assessment window, it can absolutely be used as supportive documentation to show collaboration. And if I have nothing else, I can use this form. But in our facilities, we do require this to prove collaboration. Okay. Besides the audits for coding, another good reason to ensure that your section GG is getting coded correctly and collaboratively is QRPs. Correct? The MDS items for facility performance. In a nutshell, what does it mean? Well, one of the QRP measures was added to the Care Compare and is now publicly reported as of October of 2020. So what does that mean to you? Well, it means that if you score low, you're probably not going to get as many admissions as you would have previously. If the public can take a look and they're saying, oh, they score low in this area, I'm not going to put my mom there. This is what the public's looking at. So you want to make sure that you're looking at it too. It's kind of confusing. It's when we're looking at this data, it's what it's saying is Care Compare takes a patient and they have an expected DC score based on a diagnosis, correct? It's based on how one patient has an expected DC score, and how another patient has a different expected DC score that may be significantly less based on comorbidities, prior level of function, being a max assist, maybe they have dementia. So this is what you're scored on. It's not the actual GG goals. It's based on expected DC scoring. If you are an outlier due to longer length of stay, this is what you need to consider: discharge planning. You must make sure you have documentation of medical necessity throughout the entire stay. I have to tell you, if I were an auditor and I saw a huge length of stay, the first thing that I would do is go back and take a look at what your I-20B score, I-20B was. You know, I look at that diagnosis and I say, okay, what was the expected length of stay for that diagnosis? Then I would start to deep dive your documentation. I would take a look at therapy notes. I would say, okay, if they were on therapy longer than 20 days, 28 days, 90 days, okay, closer to the end of stay, were they making progress? Was it medically necessary for skilled services to remain? Were the therapists analyzing changing goals, upgrading goals, or downgrading goals due to exacerbation of a certain condition that may have occurred? I would be looking at all of that. The next slide shows our discharge checklist. We use this DC checklist as a team checklist. It promotes us and triggers us to look at services, of skilled services being provided. So this is just one example. I include it because I think it's a very important part of a compliance program. Make sure you have a discharge checklist. Okay, and lastly, I'm going to go over in the next few slides some trends CMS has noted when reviewing RUGs versus PDPM data. Okay, remember at the beginning of the presentation today, I told you that CMS intended PDPM to be budget neutral, but in fact, they found that the SNFs actually, in fact, 90% of us did better because of MDS coding, better communication, more collaboration, and basically an overall understanding of the resident characteristics that led to better coding and documentation. Okay? The next slides give you very specific information, okay? The next slide. CMS uses PPS data to structure PDPM case mixes, but did not anticipate the teams would capture things under PDPM differently versus PPS. Take a peek at this. In your downtime, you should all giggle, nobody has downtime, but this actually goes through the trends and future implications in your risk areas. So take some time with your compliance teams and take a look and see where you fall in these areas. Wrapping it up, auditors are ramping back up and they have money to find, especially with the moratoriums on audits being up. Data is king. Outliers are in. If you're an outlier, utilize those resources that we talked about today. Pull that Pepper report. Take a look at your audits, track and trend those racks and say, okay, what do I need to do to get out on the floor and fix X, Y, and Z so that our error rate when reset isn't higher, which will make me just get more audits. Look at your nursing home compare, quality measures, QRP, staffing, survey, again, Pepper, CBR if you're one that gets the CBR, increase Part A stays, COVID waivers, make sure you're meeting the criteria that came with using those waivers. Really focus on that telehealth, PDPM case mix and rate. Where's your risk? Do you have a plan? Is your compliance program effective? That is all. Any questions? I thank you for your time today. I hope it was helpful. I know it was a lot of information, but I hope that it just sparked your interest in some areas that you can go back and look at and make sure that you have a plan in place to keep you outside the outliers and ready for any audit that comes your way.
Thank you, Heather. That was really great. A lot of information, but great information today. And I will be sending the slides out in a follow-up email later, along with Heather's contact information. So sit tight for that. Again, if there's any questions, we're open for questions right now. We'll give it a minute or two and see what we have coming in here. And again, know that if you think of something later, I will be sending Heather's contact information for you. So again, we'll just give it another minute or two. Right now, PHCA's convention registration is open. We're offering more than 30 credits during a virtual convention. We had hoped to be in person and virtual, but you all know what the COVID numbers are doing right now. So we just thought it was in everyone's best interest to just keep that virtual, and hopefully we'll get back together in person again soon. We're anxious to get back in person.
Sure.
So look for more information on our website for the convention, and also upcoming webinars. Next month is going to be, October is going to be mainly focused on those convention on-demand sessions, that virtual offering. But we are planning into November, December, and already into early 2022. We have a couple scheduled for early next year already. So just keep an eye out for those in any of our PHCA communications and on our website. All right, I'm not seeing any questions. Heather, I think you did a great job in presenting the information. And again, we're going to launch that survey at the end of the webinar today, so please take a moment to complete that. And today's webinar is recorded and will be made available on the PHCA website. And again, check out more information on our PHCA webinars. So again, I just want to thank you, Heather and Scott, for the information, for the time today. It was great information, and we're looking forward to as things progress, updates. We'll keep everybody up to date going forward. So again, thanks to Heather and Scott for your time. We appreciate it.
Thanks for having us.
Yes, you're very welcome. Again, just want to wish everybody a great remainder to your day.
Bye-bye.